Hello friends. So in today's session, let's discuss about HIV in pregnancy. So basically, I have taken the references from Williams textbooks as well as the National AIDS Control Program, which you should know as well. That's the NACP, National AIDS Control Program. All right. So briefly discussing about HIV. So HIV, as you know, is an RNA virus. It's an RNA virus. And you have both HIV-1 and HIV-2 which are implicated in this. The main mode of transmission is actually the sexual transmission. The main mode of transmission is the sexual transmission. So then what's the importance of HIV in pregnancy? Am I concerned more about the mother or the baby? The main concern about HIV in pregnancy is the transfer of this HIV infection from the mother to the baby. So, from the mother, this can get transmitted to the baby. This transmission is known as vertical transmission. So, there can be transfer of this HIV infection from the mother to the baby, which is vertical transmission, also known as parent to child transmission. So my main concern or my main area of interest is this: I have to prevent this somehow. We can do a lot of things which can actually decrease the risk of transmission from the mother to the baby. This is prevention of parent to child transmission. So we have vertical transmission. We have vertical transmission, which is also known as parent to child transmission. Parent to child transmission. So in this topic, I would be teaching you about the vertical transmission, the risk, how can we prevent this risk of transmission or decrease the risk of transmission, what are the screening for HIV that we do during pregnancy. If at all a woman is HIV positive, she comes to you, how will you manage this patient? If at all a patient directly comes to you during labor, how are you going to manage that scenario? What antivirals are you going to give? After the delivery of baby, what are you going to do for the baby? What prophylaxis or what treatment are you going to start for the baby? And a bit about the breastfeeding and vaccination during pregnancy for a woman with HIV as well. Alright, so let's discuss them one by one. So coming to vertical transmission. Vertical transmission is nothing but your parent to child transmission. Parent to child transmission is vertical transmission as we discussed. So this transmission can happen either during the antenatal period, during the time of labor, or even in the post-delivery period. How can this happen in the post-delivery period? If the mother is breastfeeding through the breast milk as well, this can get transmitted to the baby. So there is transmission during the antenatal period, at the time of labor, or even in the postpartum period when she is breastfeeding. So I would be telling you the risk, that is a percentage risk with each of this in a short time. So first, let's see what is the risk, the overall risk for the woman or for the baby to have this infection if a woman has HIV and she's not taking any form of medications. So the medications that we use for HIV is known as ART, antiretroviral therapy, which is also referred to as HAART. What is HAART? It's not the other heart. This HAART is highly active antiretroviral therapy. So, if a patient is not taking any form of medication, that is no ART, and along with that she is breastfeeding, the risk of transmission is as high as 30 to 45%. These values are from National AIDS Control Program, and you have to know this percentage. It is 30 to 45%. So 30 to 45% is the risk if the patient is not taking any form of treatment and she is breastfeeding the baby as well. Suppose the woman is taking HIV medications, the woman is on HAART and she is breastfeeding, the risk is as low as 1 to 2%. It's only 1 to 2%. If I break this down further, that is, if suppose the woman is taking HAART, that is HIV treatment, and she is breastfeeding the baby, the risk is 2%. if the woman is taking heart and she is not breastfeeding, no breastfeeding, the risk is only 1%. Okay, so if at all you don't remember this separately, you have to at least remember this on heart 1 to 2%. At least remember 1 to 2%. This is the breakdown of this as well. So now let's see what is the risk of transmission during the time of antenatal period and labor. So in antenatal period, that is till 36 weeks, the risk of transmission is 20%. Few days before delivery, there is 50% risk, and in the intrapartum period, the risk is nearly 30%. Few values which you have to know, these two values are must know. Alright, remember this. So, what are the main risk factors for transmission to the baby? So, the risk factors again could be maternal factors, factors related to labor, or fetal factors. Let's see them one by one. So, maternal factors include if the patient had a recent viral infection where she has not been started on any form of treatment, or suppose a patient has an infection, you see that she has high viral load or low levels of CD4 count. These two are very important. High viral load, low CD4 count, high risk of HIV transmission. This can come as an all except question. That is why I have enumerated all the risk factors here. You need not by heart this, but you have to have a general overview so that you can mark the answer for an all except question. So high viral load, low CD4 count. Okay, don't confuse with this. High viral load and it is low CD4 count that is associated. Any other forms of STI or sexually transmitted infection increases the risk of HIV transmission. Maternal malnutrition is a risk. Breast condition such as sore nipple, any cracks over the nipple, again increases the chances of transmission to the baby when the baby is breastfeeding. Some intrapartum factors such as we have done some form of invasive procedures to the baby, such as we have done some fetal blood sampling, fetal scalp sampling, you have done some instrumental vaginal delivery such as forceps, vacuum, any prolonged labor, or invasive fetal monitoring such as fetal scalp blood sampling. All these increases the risk of HIV transmission. Any fetal factors such as preterm baby, low birth weight baby, or in babies in whom you are giving mixed feeding. What is mixed feeding? So, either if I told you if the woman is taking some HIV medication, the HIV medication, along with that she is breastfeeding, her risk is 2%. Not breastfeeding and HIV medication, risk is only 1%. So, in patients in whom there is mixed feeding means there is some breastfeeding being given and intermittently there is formula feeding. There is formula feeding as well as breast milk which is given intermittently. The risk increases. So either you have to give no breastfeeding, only formula feed, or you will have to give only breastfeeding. You should not mix these two. Okay, you should not make a khichdi out of it. Okay, you can't give both these. If you give both these intermittently, the risk actually increases. The risk of transmission increases. So you have to know these points so as to answer an all except question. So coming to screening for HIV in pregnancy. So screening for HIV in pregnancy is offered to all antenatal patients right in the first visit itself. So whom do you screen? You are going to offer the screening offered to all antenatal patients right in the first visit itself. First antenatal visit itself. You are going to offer this screening. The approach what we use is opt-out approach. You are going to offer this screening to all the patients. If at all she says that no, I am not willing to do this, she can opt out from testing for HIV. So you are going to give an opt-out approach. So when the testing is done during labor, you are going to do a whole blood finger prick test. The whole blood finger prick test is the test that is done during labor. So now you have done the screening test, she is positive. Now then you went ahead for a confirmatory test. She is diagnosed to be HIV positive. So in these HIV positive patients, the treatment that we give is HART, that is highly active antiretroviral therapy. So the next question is, when will you start this patient on heart? What is it dependent on? Is it dependent on her viral count, or is it dependent on the CD4? When will you start this? Is there a particular cutoff for CD4 when you're going to start this heart for the patient? Previously, there were a lot of guidelines which are slightly differing on what cutoff for CD4 you are going to start this treatment. Now it is very simple. As per the National AIDS Control Program, you are going to start the patient on heart immediately, as soon as possible in pregnancy, and it is not dependent on the CD4 count. So when will you start this treatment? She has to be started as soon as possible, irrespective of CD4 count. Irrespective of the CD4 count in pregnancy. Okay, so you have started her as soon as she was detected with HIV. How long will you continue this treatment? Will you give it throughout pregnancy? Will you give it during the postpartum, that is when she is breastfeeding? Will you stop it after a few months? If so, after how many months? Again, it is very simple now. You have to continue it lifelong. Start as soon as possible, irrespective of anything, and you are going to continue it lifelong. You are going to continue it lifelong. Very important one-liners from this National AIDS Control Program. So once you have started this ART, the risk of transmission reduces to less than 2%. As we discussed, if she is breastfeeding, risk is 2%, not breastfeeding, the risk is 1%. So the risk reduces to less than or equal to 2%. The drug regimen that you're going to give for this treatment. So previously, the regimen that we were giving for this HIV in pregnancy was TLE. What is TLE? TLE includes Tenofovir, Lamivudine and efavirenz. That is TLE. Tenofovir, the dose that was given is 300 milligram. Lamivudine again 300 milligram. And efavirenz 600 milligram, which is your older regimen. Now, the present regimen that we use is TLD. What is TLD? TLD includes again the same Tenofovir, Lamivudine, but the third drug is Dolutegravir. It is Dolutegravir. The dose that you give, again the T and L is same, 300, 300 and 50 milligrams of Dolutegravir. Alright, this is the regimen that you are going to give. How do you remember? You can remember. I told you to remember the HIV drugs. I told you it's important. Told. What is told? T is Tenofovir, L is Lamivudine and D is Dolutegravir are the drugs that are given during pregnancy in heart. So now let's discuss the various scenarios where a patient with HIV has come to you in pregnancy. Either she can come during the pregnancy period where she was detected to be HIV positive and you have started her on ART, or she is already HIV positive before conception, she was on some prior HRT medications and she is now pregnant and has come to you. Third scenario is she has not been taking any form of medications. She is HIV positive without any medication. She comes to you directly in labor. How will you manage all these scenarios? So first one is during pregnancy, you have detected her to be HIV positive. So in this first scenario, as we discussed, as soon as you detect HIV, you are going to start the patient on heart. You will start the patient on heart irrespective of her CD4 count. Irrespective of CD4, you will initiate heart for the patient. What is the heart that is given? The heart that you will give is TLD. Even after initiation of this heart, you are again going to repeat the viral load of the patient. You will do the viral load testing at 32 weeks and again 36 weeks. What information will this give me? So this will tell me whether the patient is at low risk or high risk for this HIV to get transmitted to the baby. So depending on whether it is low risk or high risk, there is some difference in management of how I'm going to manage the infant, which I will teach you soon. So I'll again repeat the viral count at 32 and 36 weeks to see if the baby is at low risk or high risk of HIV. And coming to the delivery, the mode of delivery that we do for HIV in pregnancy, is it cesarean? No, it's still vaginal delivery. Vaginal delivery is the preferred mode of delivery and cesarean section is reserved for obstetric indications. Students tend to jump into cesarean section for each and everything. So there are very few indications which are direct obstetric indications for cesarean section, and HIV you need not jump into cesarean section directly. Again you will go for vaginal delivery. So I'll be soon telling you how to manage the breastfeeding, which we will be discussing soon. How to give breastfeeding, can you give breastfeeding or not for a patient who has HIV. Next is a patient who is previously having HIV, she is taking some medications on ART, she comes to you now, she is pregnant. She has been taking some form of medication, some heart. Will you change the heart? If at all she is not taking this TLD regimen, are you going to change it? There is no need to substitute the regimen. You are going to continue the same HRT. You will continue the same heart, not HRT, it is ART, also known as heart. Okay, you are going to continue the same heart for the patient. Next scenario is patient comes to you directly in labor, and when you tested her, you found that she is HIV positive. How will you test? That's whole finger prick test. So if at all she comes to you and you have done the testing and she is detected to be positive, in that scenario, you have to start the heart immediately. You are going to start the HIV treatment immediately. You are going to again also send the blood test for CD4 count, viral count, and during the delivery, you are going to follow all universal precautions for the patient. Again, these patients who are not on any form of treatment, they are high risk. They are high risk for transmission. And when it is high risk, you are going to give 2 drugs for the baby, which we would be soon seeing. So let's keep this high risk, low risk part aside, which I'll be soon teaching you how the management is for the baby depending on this. So have you understood this? If a patient has been taking some HRT treatment prior to the pregnancy itself, please don't change it. You can continue the same regimen. If at all she's not taking anything you detected during the antenatal period, start her on TLD. That is, your Tenofovir, your Lamivudine as well as Dolutegravir has to be started for the patient. If at all she comes to you directly in labor, she is at very high risk, immediately start her on HAR, and also you are going to manage the baby as a high risk baby and give the ARV, that is antiretroviral prophylaxis to the baby. So, in the intrapartum period, as we discussed, the mode of delivery is vaginal delivery, cesarean section only for obstetric indication. So, the factors that increases the risk of transmission during the delivery include prolonged rupture of membrane, any form of invasive monitoring to the baby, episiotomy, instrumental delivery, all this increases the risk during the intrapartum period. So, coming to the breastfeeding for a woman who is having HIV post-delivery. So there is a confusion whether we should give the baby breastfeeding or completely stop the breastfeeding and just give formula feed. So for a country like India, where the patients have a lot of economic problems, where they cannot completely sustain on this formula feeding, still the breastfeeding is considered better. So the National AIDS Control Program advises us to continue the breastfeeding. So put the patient on HAR and let her continue breastfeeding. The risk of transmission is only 2%. You need not completely substitute it with formula feeding. So what form of feeding are you going to give? You are going to give breastfeeding and not formula feeding. The breastfeeding, the exclusive breastfeeding has to be continued for 6 months for the patients. So again, this is directly from the National AIDS Control Program. The exclusive breastfeeding maximizes the chances of survival for the infant. Again, you know, there is a lot of benefits for breastfeeding. It increases the chance of survival for the baby, and it is the recommended method even for HIV-positive mothers. So coming to the antiretroviral therapy for the newborn. So now the baby has delivered. What can you do for the baby? You can start the baby on antiretroviral prophylaxis so that the risk of transmission further decreases. You are going to start the babies on antiretroviral. So what determines what type of antiretroviral you are going to give, till how long you are going to give? Again, initially we'll classify the babies as low risk and high risk. So what is low risk? So when you did the viral count after 32 weeks, if the viral count is less than 1000 ml, 1000 copies per ml, it is low risk. So what will be high risk? Just the opposite. When you did the counts, you found that the counts are more than 1000 after 32 weeks, or you don't have a viral load count at all. The patient is not taking any form of HRT. She directly came to you in labor. She's not taking any form of medications, or she is newly detected with HIV within the past 6 weeks. All these patients are high risk patients. So if a patient is low risk, you just have to give her single drug prophylaxis. You are going to start the patient on single drug prophylaxis. If the patient has high risk, in that situation, for that, rather than the patient, for that infant who are at high risk, you are going to start dual drug prophylaxis. In single drug prophylaxis, either we start the patient on nevirapine or zidovudine. In dual drug prophylaxis, we will add both nevirapine as well as zidovudine. Both nevirapine and zidovudine is added. How long will you continue? If the baby is low risk, just continue it for 6 weeks. If the baby is at high risk, then you again divide the baby. Is the baby breastfeeding or not breastfeeding? If at all the baby is not breastfeeding, if the baby is not breastfeeding, in that scenario, you will give this ARV for 6 weeks. If the baby is breastfeeding, then you will continue for 6 months. The simplified algorithm with which you can remember all this. Okay, divide it as low risk, high risk. What is low risk? What is high risk? In low risk, you will give single drug. High risk, you are going to give dual drug prophylaxis, either zidovudine or your nevirapine is given in case of low risk. You will combine both and give in case of high risk. If the baby is low risk, irrespective if she is breastfeeding, not breastfeeding, whatever, continue this treatment for 6 weeks. If the baby is breastfeeding and high risk, then continue for 6 months, or else it's only 6 weeks. Hope it is clear now. Finally, coming to vaccination in pregnancy. So there is nothing much new in vaccination. You can give all vaccine that you give for a non-HIV positive pregnant patient, here in an HIV positive pregnant patient as well. So what is the commonly given vaccine? You will give TD vaccine. Yes, how do you give TD? You are going to give 2 doses as intramuscular injections 4 weeks apart. That you can continue here as well. You can give the COVID vaccine. As you know, all live vaccines are contraindicated during pregnancy. You can give the killed, inactivated or subunit vaccines, which can be given here as well. This is about HIV in pregnancy. So as we discussed initially as well, all these are the key things that you have to know. You have to know what's the vertical transmission risk, how can you prevent this transmission, what are the screening tests that you do, what is the ART that you start during pregnancy, what is the antiretroviral prophylaxis, and finally, note on breastfeeding, delivery as well as vaccination. So that's all. Thank you.